Welcome to Roadmap to Residency, Evidence-Based Application. So this is the first video of our pharmacology modules, and in this video, we will be discussing about pharmacokinetics of drugs. So whenever we talk about pharmacokinetics, there is administration of the drug first. So it can be through different routes. It can be through intramuscular route, it can be through per oral route, subcutaneous route, or inhalational route. And then it gets absorbed into the plasma. In the plasma, it gets distributed as a bound form or a free drug. It can go and act to the receptors and its action, or it can go towards the liver for drug metabolism. And after the metabolism, it can go towards the excretion, or it can directly get excreted. Now let's talk about absorption. So absorption concerns the process of entry of a drug into the systemic circulation from the site of its administration. The determinants of absorption are those described for drug permeation. Intravascular administration, example, IV dose does not involve absorption and there is no loss of drug. The bioavailability is thus 100%. With extravascular administration like per oral, intramuscular, subcutaneous, or inhalational, less than 100% of a dose may reach the systemic circulation because of variations in bioavailability. Now, here you can see in this uh, curve, the x-axis shows the duration of action or the time, and the y-axis shows the plasma drug concentration. We can see that the Cmax, that is the peak concentration of the drug in the plasma, um, we can see that here there is the peak concentration of the drug, and the time taken from the administration of the drug to the peak concentration of the drug is called as time to peak. And after peak concentration, there starts the metabolism of the drug, and then there is also elimination, which gradually decreases the drug level in the plasma. Now, talking about the bioavailability, which is a measure of a fraction of a dose that reaches the systemic circulation. By definition, the intravascular doses have 100% bioavailability. So, for example, if a person is taking an intravascular bolus drug, then it does not have to go a metabolism in the liver in order to go into plasma. It directly gets deposited in the plasma. So the bioavailability for that drug is 1. Okay, 100% bioavailability. But throughout any other extravascular dose, if we administer the drug, then the bioavailability will be less than 1. Now let's talk about the first pass effect. So with oral administration, the drugs are absorbed into the portal circulation and initially distributed to the liver. For some drugs, the rapid hepatic metabolism decreases the bioavailability, and that is called as the first pass effect. First pass through the liver. So whenever we take a drug via mouth, it goes to the stomach, and then by the portal circulation in the GI tract, it goes towards the liver. Liver, since it gets metabolized, then for example, there are 3 molecules entering the liver. Through metabolism, only 1 molecule goes into the systemic circulation or the plasma. Due to that, the bioavailability of the drug decreases. Now, this is called as first pass effect. Now, let's talk about the distribution of the drug. Now, distribution is the process of distribution of a drug from the systemic circulation to the organs and tissue. Now, under normal conditions, the protein binding capacity is much larger than its drug concentration. Consequently, the free fraction is generally constant. Many drugs bind to the plasma proteins, including albumin, with an equilibrium between bound and free molecules. Recall that only unbound drugs cross by membranes. So we can see drug plus protein, which is active form or free form, gets converted into drug protein complex. Okay, now if both drug and protein gets bound, then it forms an inactive form. Now, what are the special barriers to distribution? So there are some special barriers to distribution. Placental barrier. So most small molecular weight drugs cross the placental barrier, although fetal blood levels are usually lower than maternal. Example, propylthiouracil versus methimazole in pregnancy. Now, the blood-brain is a very special barrier to distribution. It is permeable only to lipid-soluble drugs or those which are transported by facilitated diffusion or active transport. Example, levodopa. Now, apparent volume of distribution. So apparent volume of distribution is a kinetic parameter of a drug which correlates dose with plasma level at 0 time. So we can see that the volume of distribution equals to dose by concentration. Now concentration at 0 time equals to plasma at 0 time, plasma concentration at 0 time. Now this relationship can be used for calculating the volume of distribution by using the dose only if one knows the plasma concentration at 0 time. Now VD is low when high percentage of a drug is bound to plasma proteins, right? And VD is high when a high percentage of a drug is being sequestered into the tissues. Now, this raises the possibility of displacement by other agents. For example, verapamil and quinidine can displace digoxin from tissue binding sites. This VD or volume of distribution is needed to calculate a loading dose in the clinical setting. Let's talk about the redistribution of the drug. Now, in addition to crossing the blood-brain barrier, the lipid-soluble drugs are redistributed into the fat tissues prior to elimination. Now, in the case of CNS drugs, the duration of action of an initial dose may depend more on the redistribution rate than on the half-life. With the second dose, the blood or fat ratio is less, therefore the rate of redistribution is less, and the second dose has a longer duration of action. Now, since first we have administered a drug and it had gone into the CNS and it has also gone into the fat, right? Now, when we administer the second dose of the drug, now since the drug is already in the fat and it is redistributed there, then the rate of redistribution towards the fat will be low. And then in the second dose, there will be rapid um, uh, movement of the drug towards the CNS. Now, this is called as the redistribution mechanism, and it is very important in case of clinical settings. Now let's talk about biotransformation. So the general principle of biotransformation is the metabolic conversion of drug molecules to more water-soluble metabolites that are more readily excreted. Now in many cases, the metabolism of a drug results in its conversion to compounds that have little or no pharmacological activity. In other cases, biotransformation of an active compound will lead to the formation of metabolites that also have pharmacological actions. A few compounds or products have no activity until they undergo metabolic activation. Some compounds are converted to toxic metabolites, example, acetaminophen. Now, whenever we talk about biotransformation, we talk about active metabolites. Now, since if you have not understood biotransformation, you will understand it in this slide. So, biotransformation of the benzodiazepine diazepam results in formation of non-diazepam, which is metabolite with sedative hypnotic activity and long duration of action. So if there is a drug, it can go towards inactive metabolites, it can change towards active metabolites, or if there is a pro-drug, it can then change into the drug in our body and then it can show the effect. Now this changing in the different form of drugs to its different forms, drug changing into inactive metabolites or active metabolites or pro-drug changing into drug. Now this is called as a biotransformation of drugs. Now let's talk about elimination. So elimination concerns the process involved in the elimination of drugs from the body and the plasma and their kinetic characteristics. So the biotransformation to inactive metabolites. So these are the major modes of drug elimination. So the biotransformation to inactive metabolites, just like this. Then excretion by the kidneys, excretion by the other mode like bile duct, lungs, and sweat. Now the time to eliminate 50% of a given amount of drug is called as the elimination half-life or T half. Now this concept of T half is very, very important and very commonly asked in the examination. Now, whenever we talk about T half, we talk about the zero order elimination rate. So with zero order elimination rate, a constant amount of a drug is eliminated per unit time. So for example, if 80 mg of drug is administered and its T half is 4 hours and 10 mg is eliminated every 4 hours. Sorry. So if 80 mg is administered and 10 mg is eliminated every 4 hours, the time course of drug elimination is, for example, if we can administer 80 mg of drug and its elimination is 10 mg every 4 hours, then there will be 70 mg. After 4 hours, again 10 mg, 60 mg. After 4 hours, again 50 mg, again 40 mg. Now, this 4 hour is not the T half. Okay, this 4 hour is not the T half. The rate of elimination is independent of plasma concentration or amount of the body. We can see drugs with zero order elimination have no fixed half-life. So the T half is variable. Drugs with zero order elimination include ethanol and salicylates and phenytoin. So we also need to know about now the first order elimination drug. Now, first order elimination drug, a constant fraction of drug is eliminated per unit time. So the T half here is constant. So for example, the first order elimination follows an exponential decay versus time. If 80 mg of a drug is administered and its elimination half-life is 4 hours. Now here comes the concept of half-life. So if these drugs half-life is 4 hours, then after 4 hours, 40 mg of drug will remain because half of the drug has eliminated. After 4 hours, half of this drug, that is 20 mg, 10 mg, 5 mg, just like that. Now here, the T half has remained constant. And here in first order elimination rate, the T half is constant, and in zero order elimination rate, the T half is variable. So the rate of elimination is directly proportional to the plasma level. The higher the amount, the more rapid the elimination. Most drugs follow first order elimination rate. T half is constant. Talking about elimination kinetics, most drugs follow first order. The rate falls as plasma level falls. Zero order is due to saturation of elimination mechanism. Example, drug metabolism reactions have reached Vmax. Zero order elimination rate is constant, but T half is variable. First order elimination rate, since it depends upon the plasma level, if the plasma level becomes less, the rate of elimination will become less. So the rate is variable, but the T half is constant. Now let's do some question. A patient was given a 200 mg dose of IV drug and 100 mg was eliminated during the first 2 hours. If the drug follows first order elimination kinetics, how much of the drug will remain in 6 hours after its administration? Now you heard in the question thing that 200 mg of drug and only 100 mg has remained in 2 hours. Here the T half of that drug is 2 hours now. So after 6 hours, how much of that drug will remain? So 200 gone into 100 after 2 hours. In the next 2 hours, in the next 2 hours, in the next 2 hours, just like that. So one half of the dose is eliminated in the first 2 hours. So its elimination half-life equals 2 hours. With the passage of each half-life, the amount in the body will decrease to 50% of a former level. Thus, 6 hours after its administration, 3 half-lives have passed. So first half-life is given in the question, 200 to 100. Second half-life, 100 to 50. Third half-life, 50 to 25. So here the answer is 25. I hope you understand the total concept now, and this is very important concept for the examination. Next up, a subject is in whom the renal clearance of insulin is 120 ml per minute is given a drug, the clearance of which is found to be 18 ml per minute. If the drug is 40% plasma protein bound, how much filtered drug must be reabsorbed in the renal tubules? None. 18 ml per minute, 36 ml per minute, 54 ml per minute, 72 ml per minute. So the formula to use is clearance. So clearance equals to filtration fraction into GFR. So the drug is 40% protein bound. So the filtration fraction is 60%, which means that since it is bound to the protein, that will not get eliminated. So 60% of the drug that is not protein bound will get eliminated. So filtration fraction is 60%. So 120 ml per minute into 60% equals to 72 ml per minute. Theoretical clearance of the drug. Now, since only 18 ml per minute was actually cleared, there must have been tubular reabsorption of the drug. So there should have been 72 ml clearance. But since only 18 ml is being cleared, then it means that 54 ml of the drug is being reabsorbed. So the answer is 54 ml per minute. So if a drug is known to be distributed into total body water, what dose or mg is needed to obtain an initial plasma level of 5 mg per liter in a patient weighing 70 kg? So this is the loading dose question. The question for loading dose or the volume of distribution question can be used as loading dose equals to volume of distribution into Cp. Now, since the patient weighs 70 kg and 60% of body weight is water, now he has 42 liter. So 70 liter into 60% of total body water, that's 42 liter. Now, the loading dose will have become 42 liter into, that is the initial plasma level, 5. That is 5 concentration in the plasma, Cp. So 42 into 5, 210 mg. So the answer is A. One more question before we finish. So which statement is accurate for the drug shown in the example below? 100 mg 2 hour, 50 mg 2 hour, 25 mg 2 hour, 12.5 mg. The rate of elimination is constant. The elimination half life varies with the dose. The volume of distribution varies with the dose. The clearance varies with the dose. The rate of elimination varies directly with the dose. Now, first tell me whether this is a zero order kinetics or first order kinetics. So in first order kinetics, the elimination rate of a drug is directly proportional to its plasma concentration, which in turn is proportional to the dose. Drugs that follow first order elimination have a constant elimination half-life similar to the example given in the question. Likewise, clearance and volume of distribution are pharmacokinetic characteristics of a drug that do not routinely change with the dose, although they may vary in terms of disease or dysfunction. Now, whatever questions that I've discussed you with in this video are very, very important. Also, the concepts are very, very important. And to understand the concept, I have gone through these questions. So I hope that you understand the important concepts that have to be taught. Thank you for watching. Keep studying.